Hello, you are listening to the RxConnect podcast. This podcast is brought to you by the pharmacy operations at the American Oncology Network. We are committed to delivering operational, clinical, and financial efficiencies based on the most sustainable model, reshaping the future of community oncology practice. I'm your host, Melody Chang, VP of Pharmacy Operations at the American Oncology Network. Today, we continue to dive into the critical issue of cancer drug shortages, with a specific focus on navigating shortages in bladder cancer. To listen to the podcast and to read the transcript, please visit our website at www.aoncology.com. I'm delighted to introduce our guest speaker, Dr. Christopher Chay. Dr. Chay is board certified in hematology and medical oncology. He joined Messino Cancer Centers in North Carolina in 2002. He is known for his special interest in clinical research and advanced medical technology, and is highly regarded for his modern approach to patient care, incorporating the most effective treatments. Dr. Chay has been recognized for his exceptional contributions to medicine. He received the 2020 Excellence in Medicine Prize in the Professions Award from the American Medical Association, one of the highest honors given by the organization. This award acknowledges physicians who help underserved populations in the United States. Dr. Chay has been instrumental in championing an oncology medical home model of delivering quality and value in cancer care to rural areas, significantly reducing emergency room visits and hospitalizations for oncology patients in Western North Carolina. Welcome, Dr. Chay.
Thank you so much, Melody. I appreciate that.
As we continue our drug shortages series in this episode, we want to focus on bladder cancer. Dr. Chay, I know you treat many bladder cancer patients, and for the benefit of our audience, could you explain what bladder cancer is, including its common types and how it typically develops?
Yes, thank you, Melody. So bladder cancer originates from the urothelial lining, and that includes the urinary bladder, but it also includes the tracts that lead from the kidneys down to the bladder, what we would call the ureters. Bladder cancer oftentimes presents with blood in the urine. That's what oftentimes patients will see first.
Mm-hmm.
They don't necessarily have pain or discomfort, but that oftentimes gets them in to see their physician. There are two common types of bladder cancer. One would be urothelial carcinoma, and the other would be squamous cell carcinoma. Both are considered potentially invasive, and typically the diagnosis is made with a cystoscopy, which is where a urologist would go and look with a light up inside the urinary bladder. The biopsy is typically how a diagnosis would be made, and sometimes they'll even do a scraping or what we call a TURBT, which is basically a debulking of the cancer. And one of the goals of that is to identify whether the cancer is muscle invasive or not. The bladder has a muscular wall on the outside, and invasion into that muscular wall is an important part of the staging process.
Thank
Now,
you.
For superficial bladder cancers, oftentimes surgery and local treatment is enough. But if there's muscle invasion, then there's more extensive discussion of surgery and chemotherapy.
Right, right. Thank you. Thank you, Dr. Chay, for the detailed explanations. So based on what you just educate our audience, looks like the treatment vary based on the stage and the type of bladder cancer. Is that correct?
Yes.
Right. So could you further explain to our audience more about the current standard treatment?
Yes. So for muscle invasive bladder cancer, the standard treatment is typically neoadjuvant chemotherapy, which basically means chemotherapy given prior to surgery. And that would include one of two regimens, usually either cisplatin and gemcitabine, or a regimen called dose-dense MVAC or MVAC. That would be prior to surgery. And the standard after would be immunotherapy following surgery.
Mhm. Right, right. Great. So we know earlier this year, a survey conducted by the National Comprehensive Cancer Network revealed that 93% of large cancer centers are experiencing a shortage of carboplatin, and 70% have reported a shortage of cisplatin. When we look at the guidelines of bladder cancer, and we see that platinum-based drugs, especially cisplatin, remain a backbone for treatment, despite cisplatin being developed way back in 1978. So in light of the current shortage of cisplatin and carboplatin, how are treatment strategies for bladder cancer being adjusted? And what alternatives are considered most promising when these drugs are not available?
Yeah, so that was definitely a challenging time that we had without being able to use the platinum agents, including cisplatin and carboplatin.
Mhm.
As you know, we sometimes ran into difficulty anyways for patients who were considered cisplatin ineligible based on kidney dysfunction.
Mhm.
In the definitive curative setting, say for someone who has muscle invasive disease or stage 2, where we would be using neoadjuvant therapy, it's very difficult to get around the cisplatin and gemcitabine regimen or the dose-dense MVAC regimen. However, Checkmate 274, recently published in the New England Journal of Medicine back in 2021, showed the benefit of adjuvant nivolumab for 1 year after. Adjuvant means after surgery. And the benefit was quite good for nivolumab in that disease-free survival was extended to 20.8 months versus 10.8 months when immunotherapy was not given. And that was irrespective of PD-L1 staining, which we use sometimes to determine whether cancers are sensitive to immunotherapy. Also, the rate of severe side effects, grade 3 or higher, was higher with the use of immunotherapy at 17.9%, but there was actually a 7.2% risk even with placebo. So I think that for some patients, if they're not able to receive the neoadjuvant treatment because of the platinum shortage, we at least had an active agent with nivolumab to use after surgery, which was at least reassuring. Patients were getting some benefit.
Mhm. Right. How about the patients already developed the progressive disease or more so of the metastatic disease? Is there still
Yes.
using platinum as the uh, primary therapy, or is there any alternative when platinum or agent is not available?
That's an excellent question as well. So in the metastatic setting, the standard treatment has been, again, cisplatin or carboplatin with gemcitabine. However, the more recent advances have shown that there may be options for people who are unable to tolerate treatment. For example, if their kidney function is not normal, or if, during the event of drug shortages, there was a recent publication looking at the combination of Padcev, also known as enfortumab vedotin, as well as pembrolizumab. So this was conducted actually as first-line therapy, and it was given as enfortumab vedotin with or without the pembrolizumab. And so this regimen did not include a platinum agent at all. The response rate with the combination was unprecedented at 64.5% compared to single agent enfortumab vedotin at 45.2%. And about 65% of patients actually maintained their response at 12 months. Now, there was a significant increase in grade 3 rash at 17%, which is actually something that can be seen at a lower percentage just with single agent enfortumab vedotin. But that is something we'll have to look out for, Melody, for sure.
Right, right. Yeah, thank you, Dr. Chay. I think for bladder cancer patients or for any cancer patients, it's bad enough to know, to be diagnosed, you have a cancer. And then to know, and unfortunately, the drugs is not available. When the drugs, when the patients receive the bad news from their physicians, and then knowing there's a drugs that could potentially cure the disease or extend their life, but unfortunately it's not available. I cannot imagine how devastating that situations for the patients are going to be. So have you have the platinum shortage affect your patients at all so far?
So I think we've been very fortunate in AON. The pharmacy operations team has done an excellent job notifying us of expected shortages. We've been able to rotate from cisplatin to carboplatin or vice versa. And we've had minimal impact for our patients, thankfully. Now, I will have to say that while we have alternative options and immunotherapy has been very helpful for many tumor types, there are several that we have not been able to get around. And I will have to say that I really hope that we can come up with a better process for acquisition of supply, especially for some of these difficult tumor types that really do not have much in terms of alternatives.
Right. Thank you, Dr. Shays. And I know all our pharmacists working very closely with the physicians and are working very closely with the procurement and trying to find any possibility solutions we can provide and help the patients as well as help the clinics manage the inventory. So thank you, Dr. Shays. And I think that now is a holiday season. I know everybody is celebrating the holidays coming. We hope the next year's shortage is not as bad as this year. We haven't seen the shortage as bad as this year, even though we know it's been a nightmare for any pharmacist, for any physicians, especially talking about the drugs without alternative. Then we're glad to hear with the immunotherapy and with some novel therapy, and it's not only become available as an alternative, but even provide a better survival benefit to the patients. Thank you so much, Dr. Chay, for spending time with us and talking about the treatment of bladder cancer and showcasing how platinum shortage can impact patient care. I want to give you the last word and anything we didn't discuss today about the platinum shortage and bladder cancer treatment that you want to talk about.
I really think Melody, that while the shortages have been difficult for us all and difficult for patients, I think it really, at some point, we're going to look back on this and see this as a transition, hopefully away from the drugs of the past. That's what most of the shortages have been, older medications. And this will be an entry into the newer drugs, such as immunotherapy, and hopefully will really push us towards looking at newer combinations and better combinations with less side effects.
Absolutely. I totally agree with you. So before we conclude today's podcast, I want to extend our heartfelt thanks to Dr. Chay for sharing your valuable insights and expertise with us. We are truly grateful for your time and knowledge. And I'd like to thank our audience for listening. This podcast is brought to you by Pharmacy Operations at the American Oncology Network. You can listen to all the podcast recordings on our website at www.aoncology.com. We hope you enjoyed this episode and looking forward to seeing you at the next one. Thank you.